This is the Mechanical Care Forum, episode 398. It's season 13, and we're highlighting the McKinsey Institute International Diploma Program. We're checking back in with another of this year's candidates, Tim Davis, as he joins Todd Edelson in his private practice for this next phase for Tim, the clinical residency, 360 hours of practical clinical work and mentoring. This week on MCF. Hey everyone, welcome back. Thanks for joining us today as we continue to explore the McKinsey Institute's International Diploma Program, this season, season 13 of the podcast. This episode is brought to you by the McKinsey Institute International. The McKinsey method of mechanical diagnosis and therapy is globally recognized as a leading treatment for back, neck, and extremity disorders. Personally, MDT has made the single greatest positive influence on my practice, hands down. The McKinsey Institute International offers this diploma program to those professionals who have achieved prior certification in the method. It is the pinnacle of MDT training. Successfully completing the diploma program will place you amongst the world's elite in mechanical diagnosis and therapy. If you're interested in learning more, here are a couple of ways. First, stay tuned to today and be sure to follow us all along through this season, season 13, as we highlight this year's cohort of students through the program and get perspectives from the CEO of the McKinsey Institute International, this year's candidates, as we hear from some of the instructors and more. And second, be sure to go to the website to learn more about the program and how to apply. You'll find that by going to mckinseyinstitute.org and clicking on the Education tab and scrolling down to International Diploma. So this season, you've already been introduced to this cohort of 2023. We've spoken to those who lead and direct the program, some recent graduates to hear their retrospective look, some of the clinical instructors of the theoretical portion. We've checked back in with my classmates as we've met the midway point and upon completing the first phase of the academic online learning portion. Last episode, we were able to catch Tina, who you've met already, and Tui, another candidate who you've met for the first time with their instructors in Denmark in this second phase, the clinical residency. In today's episode, episode 398, we'll catch up with Tim about 7 weeks into his clinical residency. He and Todd Edelson, a longtime clinical tutor, will share about the clinic, the structure of the 9 weeks, the schedule, which includes some long days and some shorter days, and quite a bit more. Do stay with us through to the end to hear what's coming in future episodes. So here we go. Here is episode 398. Enjoy. All right. So with me today on the Mechanical Care Forum, I'm pleased to welcome back to the podcast both Tim and Todd. Tim Davis, Todd Edelson. Gentlemen, thank you so much for taking time out of your day at the end of a long day and joining me to talk a little about the clinical residency.
You're very welcome.
Yeah, thanks for having us.
Absolutely. So catching you guys at the end, you still look pretty fresh, Tim. So it must have been a good day, not too much challenges or difficulties, or maybe you just, splashed a little water on your face before we hopped on here.
A little caffeine.
Yeah, that's right. Good. All right. So before we jump in here, Tim, just remind the listeners where you're from, the clinical setting you were in, and just a bit about what you were hoping to achieve on this residency.
Yeah, I'm currently working at a private practice outpatient clinic in Montana. So I made the quick trip over here. See a lot of patients for musculoskeletal pain and as well as dizziness. And so, yeah, just things I wanted to come out here to do is, one, especially improve my communication as well as my efficiency with not only coming to the conclusion of what's going on with the patient, as well as just being able to concisely explain to them so that they can really get a good grasp of what they need to do and what the problem is.
Excellent. Yes, Todd, brief introduction, a little bit about how long you've been doing the clinical residency as an instructor in that program.
Well, thanks, Jason. I'm Todd Edelson, and I run the diploma clinical site here in New Jersey. I started in 2003, so I've been doing this for 20 years.
Yeah, excellent. All right, gentlemen. Tim, you come through the theoretical. We talked to you along with our other classmates through that portion. A bit of a gap between in the clinic, trying to catch up, trying to make up for a little lost time perhaps, and then preparation for the clinical. You were given some guidelines of what areas you might focus on, some tutorials through the program. Tell me about the preparation for the clinical residency first. What all did you do? What now, a few weeks into it, do you think maybe I might have done this a little differently?
I think the preparation, as far as what we got through with the theoretical component, was really helpful. As far as, there was a lot of things with contractile dysfunction I hadn't thought about in a long time, or some new evidence for what some of the interventions we might look at for those kinds of things are out there. And then just on the communication side, thinking about how much information we're going to be giving to patients, for one, and language that we're using. So we're not using words that are going to induce fear in a patient, as well as something that they can simply understand. So those are a couple of things I really had to just work on getting prepared for coming out here, which has been really helpful.
Great. Yeah. Todd, talk to us a little bit. We mentioned before recording that perhaps sites in Europe might look and feel a little differently. Sites in Texas and Austin might have a different feel to what you're doing. They're in a hospital-based setting there. You're a private practice. You see quite a few patients that are at cash pay. What's a day look like in this clinical residency if someone were to consider going through the diploma program and choosing your site?
So first thing I'll say is the days are long. I have an office in Manhattan as well, so I'm there on Tuesday afternoons and Friday afternoons, and the diploma candidate does not come with me to New York. So those hours are made up somewhere. So Monday, Wednesday, and Thursday, we start at 7 in the morning and we book our last patient at 7 at night. And then Tuesday, we start at 7 in the morning and book our last patient at noon. Friday is generally, I keep open in case the diploma candidate needs to make up hours. They may need to go home, or they may have some family thing that they need to attend. So Friday is usually an open day for them, but it's there for makeup hours. Or, as in Tim's case, he's here from Montana and he's not going home for the weekend. So he chooses to come in on Fridays, and the door is always open for people if they want to come in. So the thing that I see is the biggest difference between my clinic and maybe a hospital-based clinic is I'm a direct pay practice. So what does that mean? It doesn't seem like it would mean much, but what it does mean is that the motivation for these patients is very different. Somebody gets their credit card or their checkbook or cash out, they've got skin in the game automatically. If somebody's got a third-party insurer or they have an entitlement like Medicare, the motivation is a little different. Oh, somebody else is paying for that, which, by the way, they're not. And if somebody else is paying for it, then we're all paying for it. So the motivation is very different. Very rarely do we see motor vehicle accident or workers' comp unless they decide they want to pay directly. So once again, the motivation is very different. And, I think back and I liken it to the types of patients that Robin saw. He saw people who came in and they were motivated to get better. And that's how my clinic is set up. Well, don't get me wrong, we are Medicare providers because we feel like we should be giving back to the community. But, we try to train our patients to be independent rather than dependent, which is really the essence of this whole system, isn't it? So it really fits right into hosting a diploma program.
Yes. Excellent. No, that's very helpful. Tim, will you speak on that? You're coming from a clinic that's insurance-based that does different, of course, than what Todd's clinic does. What can you say about that difference? Have you seen it? Is it palpable in terms of patients, or is it subtle?
I think it depends on the patient. I think by and large, here, there, you can definitely tell we're getting a lot of people very motivated right from the get-go. Whereas coming from the other side of things, some people might not quite be at that, stage of readiness right when they come to see you. And that can certainly influence how fast things move along. So yeah, that part of it, yeah, not with everyone, but it can certainly definitely play a role in not only outcomes, but how quick you might get there.
Mm-hmm. Also, tell me about the pace at which you see patients. Are they different times in terms of multiple body parts? You're seeing a little longer. Are all the follow-ups a certain time frame? Are the examinations, the initial evaluation, are those a certain time frame? How long you're seeing them?
When people come here and they're paying out of pocket, they don't expect that I'm treating 4 or 5 other people, or Tim and I are treating 4 or 5 other people at the same time. So we book an hour out for each evaluation and 30 minutes for follow-up. We don't double book. And let's face it, sometimes somebody comes in late, somebody's coming in early, and there's a little overlap. But if I'm seeing one person at a time, the schedule can really absorb that. Yeah. So there's
Very
plenty
good.
of time for the patient, and there's plenty of time for us, the clinician and the diploma candidate, to really go through a meaningful thought process.
Mm-hmm.
It's not rushed.
Mm-hmm. Guys, there's about 9 modules in the clinical manual and topics that are meant to be covered. Todd, how do you go about that? Do you go start at 1 and take it all the way through the 9th once per week? And when do you do the tutorials, and how does that work?
I'm not quite sure what other folks are doing now about tutorials, but about 20 years ago, I learned pretty quickly that the diploma candidate gets a lot more out of doing the tutorials than me telling them, for several reasons. Number one, you get to prepare. Number two, you have to be concise in relating that information, which really helps you in your patient education. Number three, you have the ability to hone your presentation skills.
Mm.
So for all those reasons, much better for the diploma candidate to do that. So the first week is on taking meaningful history. So I do that. I go through the evaluations for the cervical spine, lumbar spine, and upper and lower extremities, just so that the diploma candidate can get a sense of how they may want to do it. I don't put any limitation on people, although I do tell them, if you're talking for more than an hour, at that point, I'm probably going to stop listening. So some people choose to do PowerPoint. Some people choose to have an extemporaneous conversation. And I don't put any limitations. It's people can use their own presentation style. I really try to follow the manual because it's much easier for everybody that way, because the diploma candidate, before they get there, they have the manual. There's a certain expectation. I don't need to be jumping back and forth to remember what I've done or what I haven't done. Yeah, so I find that way it really works out quite well. And the most interesting things happen every time, and it never fails. We go over a topic, that patient shows up the next day.
Yeah.
Does that seem to be the case?
That's for sure the case, yeah.
A little ironic.
I don't know how the Institute managed to do that, but it's quite spectacular.
It's magic. So, Tim, have you taught on serious pathology yet, or ruling out red flags?
Yeah, I think that was week 1. No, it's kind of blended its way into most weeks, though, actually.
Yeah. Yeah. And so just from off the cuff here, putting you on the spot here, buddy, tell me a little bit about what were some of those key points that you read about and studied and then presented to Todd about red flags and ruling out serious pathology.
I think I get just a better understanding of, the whole person as a complete picture, thinking about, I don't know, for instance, fracture risk, how, was there a trauma? Okay. Yeah, but perhaps they've been smoking 20 cigarettes a day for the last however many years, or maybe they've they're doing other things that might put them at a much higher risk of a fracture, and osteoporosis is one, but maybe they might have a type of condition where they're not able to absorb all the nutrients they're taking in from food, and Crohn's disease, and so they have a weakening of the bones from that regard, or a lot of different body systems that can be involved in that kind of a problem. And so I think just from taking into account every body system, I got a little bit of a better grasp on that and how to dig a little deeper if something's, if we're trying to tease out if this could be a serious pathology or if they're going to be safe to move.
Mm-hmm. Yes, excellent. Tell me a little bit more about the tutorials. Do you guys do them at a specific time in the week, or is it between patients if someone were to last minute cancel? Is it impromptu, or is it structured and scheduled? Todd?
It's pretty structured this way that, it's not a moving target. It's hard enough to present as it is. So to make things structured and at the same time every day works pretty well. So what we do is we finish our morning at about noon. We have lunch, and after we're finished with lunch, then Tim will do the tutorial. Mm-hmm. And that way there's plenty of time. It's not rushed between patients. And if we get behind or we have other things to do, and we don't have a patient at, say, 7:00 in the morning, and Tim is here at 6:45, I'll say, okay, let's just do the tutorial now.
Got it.
Yeah. And that gives us a little leeway later on.
Sure. Todd, you're aware that in Denmark and France and in Texas, oftentimes there are two students that come together because they've got more than one clinical instructor, of course.
Yep. That
never has been the case for you, right? It's always been one student at a time.
No.
That's not true.
I can take two people at a time, and
you do.
And I would say about once a year I take two people at a time. So I'll see I have a block in the fall that goes from September through the first part of November. And I have a block in the winter that goes from the first week in February through probably the first or second week in April.
Mm-hmm.
Yep. So frequently I will have two people here.
Got it. Sorry.
What's really interesting is that when I have two people here, they say, I would not want it any other way.
Yeah.
When I have one person here, they say, I would not want to have this any other way.
Yeah.
So the benefit to having two people is that they can work with each other.
Yeah.
And it's interesting because they help each other.
Mm.
If I ask a question and somebody doesn't know, the other one person comes in like the older sibling to help out.
Yeah.
And it's very interesting. When I have one person here, the way I view it is like, if you have one child, all your attention is on that child, which is fine if they're just one child. But if they have a sibling that goes off to college and then they're the only one, they don't like all that attention so much.
Sure.
So it's just very interesting. And again, it depends on the personalities. Most of the time, the people who come together, they really mesh very well.
Mm. Yeah, excellent. Yep, and I've heard similar sentiment from Chris and Kim in Texas. They see people usually doing just that, just like you say, helping each other out and having each other's back. Tim, you mentioned a little bit about your goals of just improving communication skills, just fine-tuning your clinical reasoning. Was there anything else that you felt like, I'm just not as confident on extremities or on the chronic pain, yellow flag type of patient? Did you have anybody in mind or any type of patient that you felt like, I hope that I can get this ironed out or that clarified, or was it just the full picture?
For sure, the full picture. Yeah, more extremity experience is going to be great for me because I see quite a bit more lumbar and cervical spine as far as what people are coming in with. I was hoping to see lateral shift deformity. I haven't seen a whole lot of those surprisingly, but we were able to see one of those here, which was really helpful also. So yeah, everything we've done has been pretty helpful, but those were kind of some of the bigger ones on my end, just as far as I haven't seen as much of.
Yes. Yeah. Todd, what are your goals for the residents when they come through from a kind of an overarching view and then maybe from a case to case view or a student to student view?
So I think the overarching view is to have the person who comes in here to do the diploma program leave a self-learner.
Hmm.
It's interesting because by week 8 or so, people are really competent. And then they'll say, well, like, yeah, but I'm going to be leaving. What do I do now? And I said, well, you have all the tools. And so it sounds trite, but remember what Robin said, my patients taught me everything I know. So if I can give the diploma candidate the tools to teach themselves, then I think I've done what I'm supposed to do.
Mhm. Mhm.
Because we do the same thing for the patients too, don't we? It's
Absolutely.
no different. It's a
Right.
little different window dressing.
Yeah. Yeah.
Mm.
And do you have any parting words of wisdom for them specifically on how they do that? Is it just to read the journals? Is it just to audit courses? I know you're a strong proponent and have for a long time held study groups. What are you saying to the residents typically about, ways to be a continuous kind of lifelong learner?
Yeah. So the main point is just to listen to the person that's sitting in front of you
Yeah.
because they know more about their problem than anybody. So it's a pretty good idea to listen to them. And I think Tim will vouch for this. Everybody that's walked in here has told us what their problem is. They've told us how to treat it. And then they've told us what they want out of this.
Mm-hmm.
And I think that's really to the person, right?
Absolutely.
Yeah. And it's interesting because no matter, sometimes we get patients who just, they talk a lot. And I think it's a whole healthcare system that's made that happen, right? Because people, they go to a healthcare provider and what they get on average is about 8 minutes,
Yep.
right? So now you have competing interests. The patient has their 8 minutes to get everything out that they need to get out, and the healthcare provider has their 8 minutes to get that person moving on. And there's no way that that does this, that does this.
Yeah. Creates barriers and yeah.
So what we tell people right up front, you are going to have plenty of time to tell us your story. And we need to hear it. And it allows them to relax. It allows the diploma candidate to relax because then okay, I have time to get the information. There's not a rush. And I think it's not about being fast. It's about being accurate.
Mm.
Right? What's the Navy SEALs saying? Slow is smooth, smooth is fast. Yeah.
Yeah. As you're hearing Todd comment on articulating to the patient to set up the experience with the patient, that you're going to have time to tell your story and we want to hear it in full, does that bring to your mind that, yeah, I can see myself having changed a bit in how I conduct the history or what I say to begin with, or how I give the patient a sense that we're going to sit here and talk as long as we need to, type of thing? Have you seen that different than what you were doing prior?
Yeah, absolutely. Yeah, first thing we'll tell them is, we're going to ask you a lot of questions. At the end, if there's more information you think we're going to need to have, we'll need you to tell me that. But there's going to be plenty of time for that at the end. So just right off the bat, setting it up
Mm-hmm.
puts them at ease. And during the interview, I think I've changed a bit too. If they're going to tell you a few things, but then sometimes floodgates are going to open. You got to make sense of what they're trying to tell you in an organized way. And so we might just stop for a minute. Hey, I'm going to ask you about that in just a minute. I don't want to miss anything here. Let's back up.
Yeah.
And so just framing it in a way that you can get them a little bit more on track, but also they know, well, he's really interested in what I have to tell him.
Yeah. Yep. I was in Texas not long ago, of course, finishing my clinical residency, and I'm coming out with the patient, sending them off to get scheduled for follow-up. And Chris said, well, what do you think? And I'll comment, and he'll make a comment, about maybe a patient who seems like there's fairly strong cognitive, emotional barriers here, yellow flags. And I'm like, really? I don't know that I would have picked up on that day one. And so there were times where I thought one thing, Chris is thinking another. We weren't sure, either of us, fully what was going to happen. Of course, it kind of panned out with many of those patients. And, yes, Chris was probably right more often than not. But at any rate, it was just really interesting to me to think one thing, hear him thinking something different, us chat about it a bit right afterwards, and then follow through with that patient and see. Tim, I've asked you to look at a patient or two just to hear your thoughts about maybe some piece that was a good moment of learning in the clinical residency. So walk me through just a little hint of a flavor of maybe some of this same thing that you guys might have come away with from a patient where you thought, I don't know that I saw it that way. Let's see what happens. Any patient come to mind?
Yeah, there's one that comes to mind. So there's a patient that came in to see us for low back and thigh pain. So I'm getting going with taking the history. Oh yeah, this is great. I've been trying to work on how efficient I am with the history, getting him back on track. If he's going off about something, it's like, oh, this is going great. I think I know just exactly what's going on here as well in an efficient manner. Feeling good about that. Patient stands up. I took one look at him. He stood up. I was like, oh my, this guy shifted to the right. He shifted to the right. I could have saved 20 minutes of questions because these people are sitting there pretty uncomfortable. They're not feeling good. They're shifted. So just, if I had looked at him right as he was walking in, I would have probably noticed that. So instead of taking 20, 25-minute history, hey, that shift come on when the back pain came on? Are you safe to move? Okay, we got to correct the shift and get on with it.
And Todd, I'm assuming that you saw that when Tim might have missed it.
Well, what I always think, and you'll know this from raising kids, teaching is not telling. So I saw the guy walk in and he sat down. And if I said to Tim, look at him walking in, he shifted, he doesn't learn anything. Taking 20 minutes to ask him questions that may not be relevant based on the presentation, he's never going to forget that.
Yes, that's right.
Right. And I mean, quite well that the things that we learn most are the things we do wrong. You learn nothing by being right all the time.
Mm-hmm.
So if it's not a safety issue, I will let it go. Why? Because it's going to become a much greater learning experience.
Yeah.
And I think that's because I've made so many mistakes in my career. And the biggest ones, these are the things that I learned from.
Yeah.
And I think most of us do.
Mm-hmm. Tim, talk to us about extremities. It's a common thing that we hear from some clinicians going through McKinsey courses, MDT courses, where they feel confident applying these principles to the spine patients, but extremities, they just kind of feel themselves falling back into that more conventional therapist. And so you mentioned briefly that you see mostly spine back home and you were hoping to see some extremities. Any patient come to mind that was an extremity patient, and what were maybe some pieces that you took away from that?
Yeah, like it's probably week one. You just got to think about it just the way you think about the spine. So as a patient coming in for knee pain, they start sitting for a while and it's hurting. They express that they're having a difficulty bending their knee. They can, they're rising up and they got some difficulty straightening up. They take some steps and then it starts to ease up. But initially what stuck out me, oh, this person has a difficulty bending the knee. Maybe we need to start flexing their knee. But if I listened a little bit more intently right there, this sounds just like a lumbar spine extension responder. So let me know, hey, think about the spine here. This might be a person that we should actually extend for that reason. And so that was helpful right off the bat. Just thinking about it, there might be some different degrees of freedom in some of these other joints, but they behave really similarly to the spine.
Mm-hmm. How do you see a theme from residents coming through where there maybe is a bit of a confidence difference when treating patients with spine versus extremities?
Oh, it's huge. It's not a little, it's huge.
Yeah.
It's almost as if, the spine is one animal and the extremities are a different animal. And the way I look at it is you have these joints that are synovial joints, right? You got a bone surrounded by a synovial membrane and maybe some cartilage in there. Well, that sounds just like the spine. You know, nature is pretty clever, right? A million years of evolution has figured out that if we're going to use a different method to heal every one of these different joints, you have no energy left to live. So nature comes up with this really clever way to heal these joints. They behave the same way. And we need to look at the extremity joints exactly the same way. And what I tell the diploma candidates is bring it back to the spine. Like the patient that Tim mentioned in the first week. Painful sitting with their knee bent. Okay, they're having trouble bending their knee. Well, if it's the spine, they get up and they walk and they start moving. You would have no problem saying, oh, they're better when they walk. They're better when they're extending. That's going to be an extension responder. Maybe I need to test that. No different in the extremity joints. No different.
Mm-hmm. Yeah. Two good examples. And I know that communication has probably come up. Tim, can you think of an occasion where you perhaps were educating a patient on condition management, not so much maybe diagnosing, but once you have it confirmed, yeah, we're dealing with this or that classification, educating the patient on them understanding why do they need to do this and how many repetitions, and what if I feel pain, doesn't that mean I should stop? Are you picking up on any tools and any principles that maybe you weren't using before in terms of communication?
Oh, we definitely give the traffic light guide out to everyone, letting them know safe versus not safe pain. And then just as far as them, understanding, I think something that's been helpful for patients to hear about why they're doing a certain, if they have a directional preference, why they're doing that exercise and not something else, is thinking about, we take a pen and we stick it in a door jamb. This tiny little pen can cause a huge problem as to how this door is able to function. If we move it the wrong way and we make a huge mess, if we move it the right way, the thing gets out of the way, and that's a really well functioning door all of a sudden. So they can think about it in a way that gives them a little context, and for one, that's the way they might be a little less fearful about their condition, and two, that's just the way they can understand it in a simple way.
Mm-hmm. Mm-hmm. Todd, we know that clearing the spine is a pretty huge piece that we've learned to appreciate with more recent studies like Rastogi and Rosedale and all these good researchers that we've seen it, of course, for a long time, but seeing it in peer-reviewed journals oftentimes gets a greater maybe following, or at least gets people onto the topic. Have you seen clinicians change over the years in terms of the challenges that arise, the hangups that we all have, or is it kind of just the same thing?
No, I think just as you mentioned, people are really aware of these studies now. And I find that at least the people coming through my site, they are well aware. 10 years ago, even 5 years ago, people would just go right to the joint. Don't do that now. Mm. They'll look at me and they'll say, I think I would clear the spine first. Everybody's onto it. Mm-hmm. And it takes almost no time.
Yeah.
But if you miss it, you got to then go back. You've got a patient who spent maybe 4, maybe 5 days, maybe a week doing something that's not been helpful. Maybe they're so agitated they don't come back. And of course, you get the patients who come in, they have their prescription that they have a knee pain with bone on bone, and they're coming for strengthening of their knee. And you need to explain to them that, okay, we're not going to treat this in isolation. We're going to look at everything that has anything to do with your knee. And you have to ask them permission. And the last thing you ever want to do is get between that patient and their physician. It's unprofessional and it's just not helpful.
Yeah.
But if you explain to them, we want to be really, really efficient, but we also want to make sure we don't miss anything. Do you mind if we do this? And almost invariably they'll say, oh no, I appreciate that.
Yeah.
But as far as diploma candidates that come through, people are on board. They just know.
Yeah. Yep. Yeah. Tim, you're majority way through now, correct?
Yeah, that's the start of week 7.
All right. So you're in that home stretch. So just don't mess it up, right?
Right. Right.
Yeah. Yeah. So as you're nearing the end, where's your head now? If you're looking at, we heard from some recent graduates and now diplomats saying, oh, it was week 3 and it was the tendinopathy week and theoretical. And I really felt myself grow. Other people, no, it's the clinical. Some people look at it and it's just the whole thing, or maybe it's even afterwards they realize, okay, I can see how I've grown now. What would you say about these moments through the program and where you've seen clinical growth?
I think in both sections, really, for when the theoretical was just a good reminder, I can complete a really difficult task. So it was a little bit of a confidence booster, really, because it was hard.
Yeah.
But it's what we all signed up for sure. But I think so in that aspect, that was helpful. And then as far as growth goes, being just, I think, a little bit more aware of all the research that's out there and just a little bit more familiar with that in terms of musculoskeletal care as a whole. That was really helpful during the theoretical component. And I'm a little bit more on top of it now and know how to stay on top of it better going forward. As far as growth in the clinical goes, though, it's definitely where a lot more day-to-day change. I can see that more so than the theoretical component, which we absolutely had to do to prepare for this. But yeah, like Todd was saying, you can read about someone walking in with a lateral shift or something like that, but until you go through, you talk to him, and then you realize, oh my God, this guy had this whole time, and I used up 20 minutes when we could have been correcting the shift. You can read about those things all you want, but until you see it and you work through it, it hits home a little bit better. It's going to stick. And now you've got some information of what you can do a little bit differently and what went well going forward. So that's been where a lot of the growth has come from, is from the clinical component.
Yeah. Some people might think, man, I just cannot imagine sitting in front of a senior faculty and trying to conduct a history and then the physical exams, just too intimidating. What would you say to that, Tim, to help someone out there who might be thinking, yeah, I'd like to do it, but I don't know that I could do that?
I think that's kind of my thought going into it too. I'm not going to know anything compared to this guy, of course, but what Todd does is just, you're going to be out of your comfort zone. You just think like, I'm not here right now. You're going to see me writing things down, but don't worry about that. And, when we go over this patient, Todd's going to ask you, hey, what went well? He's not going to be like, hey, you screwed this up. You screwed this up. Okay, what went well?
He may be thinking that, but he won't say it, right?
Yeah, sure. Yeah, but we went over what went well, and then, here's just some things that we can do a little bit differently that might be more effective. So it can be an intimidating situation to walk into, but in the way Todd goes about it is, you're not going to be ridiculed. It's going to be just a really nice learning opportunity.
Mm-hmm. Todd, what would you add to that?
Well, I would say, look, we've all been in this seat, every last one of us, and it is really difficult. Hard enough to learn in a positive environment, but when somebody's telling you, this is what you did wrong, this is bad, that's what you're going to hear. But if you hear, look, tell me what you did well, because our heads don't go that way, but you got to start thinking that way. And then, okay, great. What would you change? Because people know what they would change.
Mm-hmm.
And then at the end of week 6, we do this thing with video. I videotape the diploma candidate doing an evaluation. And we always have this sense in our head about how we're communicating. and how we interact with people. But when you see it on a video and it's memorialized, it's an eye opener and probably the single most effective teaching tool throughout the whole diploma program.
Mm-hmm.
So what I would say is, from my perspective, people aren't here to change everything. They come in at a really high level. And my job is just to get them to be as good as they could possibly be. And I don't think you do that by browbeating people.
Right, right. Well, I know that it's getting late there after your long days. You've had to make it even longer, so I appreciate that. Tim, you're in your home stretch, not to get complacent or anything, but I'm rooting for you, my friend, and I know you'll finish well these last 2 weeks. Yeah. And then nothing more to do other than just study your butt off until your exam, right?
Yeah, you'll probably tell me about that.
Yeah, that's right. Yeah. So I appreciate you guys extending your day. Thanks for Tim for sharing just your firsthand experience. Todd, thanks as always for giving your perspective on what you're looking for with these residents. We appreciate you guys helping out with season 13 here, and thanks for joining the podcast.
Thanks for doing what you do, Jason. It's great service.
Yeah, it's been really helpful for me over the years, for sure. Yeah, thanks, Jason.
Okay, so there you go with episode 398. It's good to catch up with Tim to get a feel for how this clinical residency site has its own unique feel, yet still accomplishing similar objectives as the other sites. Stay tuned for Emily and myself, joined by Chris Chase, our clinical tutor in Austin, Texas, USA. That coming up next episode. Hey, don't forget to subscribe to my email updates to be notified of new episodes. You can do so by clicking on the sign-up bar at my website. Subscribe to the podcast on your favorite podcast player and follow me on social media channels, as we'll be notifying you when each episode comes out. If you're hearing this audio version, do know that we are releasing video versions of the podcast on our YouTube channel too. Again, we want to thank today's sponsor, the McKinsey Institute International, providing worldwide training and support to clinicians in the principles and practice of the McKinsey method for the management of patients with spinal and extremity disorders. The McKinsey Institute International Diploma Program provides the highest level of MDT training. It enables clinicians to acquire an in-depth understanding of the McKinsey method and become experts in its effective use in guiding their patients to achieve their personal goals. If you have an interest in learning more about the diploma program, check it out at mckinseyinstitute.org. And if you've heard enough and you're ready, you can apply to enroll in this program through mckinseyinstitute.org through October 31st of each year. By the way, we're continuing to plug away here at Mechanical Care Forum with new cases within Case Conversations, our patient case discussion resource, and new scientific studies within Inside the Science, our peer-reviewed summary and discussion resource. Currently, regarding Case Conversations, we have multiple years' worth of cases built up in the platform, from topics like lateral shift to articular dysfunction, to the importance of getting into the thoracic spine, to balance and dizziness cases, to know when to go lateral, and how best to communicate with patients, and on and on. And within our research resource, Inside the Science, we also have an ever-growing collection of study summaries and discussions on papers like the AXPOS study, on conservative versus surgical management of the ACL, on Audrey Long's Does It Matter Which Exercise paper. We touch on the paper itself and important keys to the methods, the most important data which came from the paper, the clinical implications, and more. These resources, both Case Conversations and Inside the Science, are intended to provide some virtual mentoring for you and help keep you moving forward in your professional development. You can check these out at mechanicalcareforum.com. All right, we wish you a great week with your patients this week. Remain ever learning. Seek time with others. Oh, and don't want that patient in front of you to be anything. And join us right back here next week for more from Season 13 and sharing experience for improved patient care.